thank you for SEMVMA for inviting me to speak tonight. And since she already introduced me, I won't go through all of that. But and welcome to the people on Zoom as well. I heard that we've got some people from New Zealand joining us, so good morning to all of you too. It's evening for us, so we're going to do this in two parts. So I took the LVTs part out of the title here. I know it was in the original listing, but I figured some of this information could be useful for all vet staff and not just LVTs as well. So we're going to start with cardiology basics to kind of warm ourselves up before we get into ECGs, which can be a little bit more intimidating for people. So while I was trying to figure out what would be helpful for everybody, so with cardiologists and cardiology practices booking out like 6+ more months in advance, I figured we'd talk about the most common diseases that everybody is going to see in everyday practice, and then how we can make an educated guess based on signalment, which is super important in cardiology, and then putting that together with exam findings, diagnostic testings, to make kind of an educated guess on maybe what might be going on with this patient while you're trying to get them into cardiology, and then what you can do for them in the meantime while they're waiting to be seen. There are waiting lists, pets can be on to be seen, but sometimes it still can take weeks to come off of those lists, and we don't want pets dying on those waiting lists. And so there are a lot of things that you can do in the office to help cardiology triage some of these patients for more urgent care, and then maybe even starting medications on them in the meantime so they don't die while they're waiting on our cancellation list. So I'm not going to insult anybody with anatomy, but I did figure that we would start with a good old-fashioned anatomy review. So for the first portion of this, we're going to be plumbers, and for the second portion of the talk will be electricians. So for our plumbing review, so we'll start with blood coming from the body, deoxygenated blood into the heart. So it's coming in, coming into the right atrium, through the tricuspid valve, into the right ventricle, out through the pulmonic valve and the main pulmonary artery, out to the lungs, and then blood coming back from the pulmonary veins into the heart, into the left atrium, through the mitral valve, into the left ventricle, out through the aortic valve, and then out to the aorta to the rest of the body. So these are a lot of the abbreviations that we'll use. So signalment is huge in cardiology, and age and breed really, really matter to us. A lot can be determined when you look at a patient's age, breed, and we put that together with your exam findings, any of the clinical tests or diagnostic testing that you're doing. We can make some really good guesses on what might be going on just based on these things alone. So, for example, Cavaliers. You see Cavaliers all the time with valve disease, but did you know that Cavaliers can also have atrial premature contractions, just normal? So they'll have APCs, you'll listen to them, and you'll have like this young 1 or 2 year old Cavalier in the office, you're like, oh my gosh, it has an arrhythmia, and then look at it on an ECG, and it has APCs. That can be a normal finding for Cavaliers, so that wouldn't really bother us. And like Yorkies up here, Yorkies and Pomeranians get a lot of tracheal disease, so it really matters what patient you're dealing with. They're not all the same. So we will start with valve disease, degenerative valve disease, or myxomatous valve disease, if you want to sound really smart and refined. We'll just call it valve disease. And we're going to start with this because it's the most common disease that we see in practice. So it accounts for 75% of our cases. We see it all day, every day. It's usually pretty straightforward, pretty linear disease in dogs, pretty predictable. It's an adult onset disease, so typically don't see this in young animals. So Cavaliers can get it kind of young, but for the most part, small breed older dogs are what we're going to see with valve disease, although medium to large breed dogs can get it as well. So obviously we're gonna see them a little bit earlier than we will the smaller breed dogs. But it's a breakdown of the connective tissue. So just like in the rest of our body, we have connective tissue everywhere, and as we age, that connective tissue breaks down over time. And your valves and the chordae tendineae that attach to your valves and anchor them are also made of this connective tissue. And so that tissue can get thickened and degrade over time, and that's what causes the valve leaks. And so as those pets get older, that process just continues to progress over time, and so then you get the progression of their disease. So it occurs over a period of months and years. Rarely do we send these pets for surgery, very rarely. Most of the time we're managing them with medications. So our list of small breed dogs. So Cavaliers obviously at the top of our list, and they're our mascot for a reason. 80 to 90% of Cavaliers will get valve disease at some point in their life. So always be listening for murmurs with them. Dachshunds are in second place. We see tons of valve disease in them too. And weirdly, Dachshunds are the #1 breed for rupturing their left atriums. So you get a big enlarged heart and big enlarged left atrium. Those dogs will often tear their left atriums, and then they'll have pericardial effusion. And so it's just kind of a weird dachshund thing that they'll do. Poodles, all sizes of poodles, which is one reason why it might not be a great idea to make doodles, because you're putting this poodle genetics into everything, and so now we can give them genetically, propensity for valve disease. And then all the other small breeds that we see, Pomeranians and Yorkies, obviously these dogs have a huge risk for tracheal disease, which can kind of exacerbate issues and what owners see at home with coughing and whatnot. Terriers, as far as medium to large breed dogs, like I said, we see lots of doodles, and pit bulls, retrievers, whippets, greyhounds, eagles. And really any breed can get valve disease, but these are just kind of the ones that are like overrepresented to us. We don't typically see like Arctic breeds or anything like that with valve disease, just kind of not typical for them. So like I was saying before, valve disease is a gradual breakdown of their connective tissue. It most commonly affects the mitral valve on the left side of their heart. But you can get degenerative changes in your tricuspid valve, and it can actually affect all the valves in the heart. But mitral valve is obviously the most common. So usually the progression of this is it'll start out as a soft murmur, because as that valve starts to leak, that's what you hear is the murmur. And typically with valve disease, smaller leaks mean quieter murmurs, not always, but a lot of times it does tend to correlate with how big the valve leak is. So it'll start out as a soft murmur and gradually increase in loudness over time as the valve continues to break down and you get a bigger leak in that valve. And we'll talk about, but bigger leaks cause the heart to be a lot less efficient. So if you think of it, all the blood in your left ventricle is supposed to, with every contraction, get squeezed out into your aorta. Well, with every beat of the heart, if you've got blood going backwards through your mitral valve into your left atrium, first that creates a lot of extra pressure in your left atrium, but also that just makes your heart a lot less efficient. So small leaks your heart doesn't really care about, your body doesn't really sense that, but bigger valve leaks cause a problem because your body recognizes the fact that, wow, I'm not getting this output that I think I should be getting with every beat. And so now we start this like domino effect of activating hormones and things like that help drive heart enlargement. And then obviously the bigger your heart, the higher your risk for heart failure. So, and we all know the symptoms of heart failure: coughing, rapid labored breathing, weakness, collapse. And so that brings us to the renin-angiotensin-aldosterone system. So I won't bore you guys with all of the specifics of this, but RAS in cardiology is huge. And not only do we go after heart failure with Lasix and things like that, but you really have to go after them kind of in the back doorway with their neural hormones, because the system gets turned on when your body senses that it's not getting that output that it needs, specifically to your kidneys. And so it's important for clients to know this, so at least if you have the gist of it, you can help inform clients, like if you're putting them on these medications, why this is important and why this is gonna help their dog with it. So the takeaway is RAS controls your blood pressure and your overall blood volume. And so we go after it with ACE inhibitors like anazepril and enalapril, and aldosterone blockers like spironolactone, because those hormones that cascade, which is why I kind of put a little domino effect in the background, really does cascade down and drive heart enlargement, and it drives you toward heart failure. And so if we're not controlling that, then you can give them Lasix and stuff, but you're not kind of shutting down this process that's driving it forward. And so when you're retaining salt, you're retaining water, you're increasing your blood volume, your heart has to grow to accommodate that blood volume. So we have to try to shut down some of those hormones to kind of stop this cycle. Valve disease is graded by ACVI, and I won't go through all of this, but I figured I would include it since there is an official grading system for it. Stage A and B are asymptomatic, so these pets are not in heart failure. Stage B2 is kind of the sweet spot for starting medications. So the studies show that starting pets on Vetmed, once they start showing signs of heart enlargement, so like on echo or on chest x-rays. So there's really no benefit to starting them, even if they have a valve leak, if they don't have any heart enlargement, because that kind of tells you, well, your body's handling that okay, so you don't really need medication yet. But once we start seeing that there's some heart enlargement there, that's when you want to step in and start some medication for them. So the picture on this, I had to leave this because I thought it was hilarious. Don't try finding a murmur by listening to a dog this way. There are tons of pictures like this. So I just thought it was funny. So obviously you don't listen to them at the front of their chest. But so you can get dogs walk in the door, and these pets are asymptomatic typically, but listen to them. They'll have a new or a history of a soft or moderate intensity murmur. So soft murmur, we're talking about like a grade 2 murmur. Sometimes grade 1 murmurs are even missed. The dog's panting or trembling, or moderate intensity murmurs like a grade 3 or 4. Their heart rates will be normal. Sometimes they'll have sinus arrhythmia, which is actually a good sign. So sinus arrhythmias obviously are normal in dogs, but when your heart starts to struggle, your sympathetic nervous system kind of takes over and drives your heart rate up to try to make up for the fact that your heart is not performing well. So you'll lose that sinus arrhythmia. So if you're listening to someone and they've got a nice slow heart rate and sinus arrhythmia, that's kind of a good check in their direction just right off the bat. Normal breathing, normal pulses. This is an echo of a mild mitral regurg dog. So let's see if I can play this. So give you a lay of the land. So left ventricle, mitral valve, left atrium, right heart is up here. So we've got color flow on this. And so this, I wonder if I can get it to play again. So this like squirt of bright blue here, that's the regurg. That's the mitral regurg. So this is a small leak. This dog had normal cardiac dimensions on its echo. So even though it had a valve leak, it had a murmur, it didn't have any heart enlargement yet, but then you know, okay, this dog has heart disease, and now we want to see you back in 9 months or 12 months or whatever to monitor this, because we know that this does progress over time. So your to-do list for these dogs that come in and they're asymptomatic is, well, I guess I should back up. If they are symptomatic at any point, so let's say this dog comes in and has a grade 2 murmur, but it's coughing, well, we should still take chest x-rays on that dog because it has respiratory symptoms. So there's still a lot of other things or other reasons why that dog might be coughing, that we could do something about. So, but that would also give you a lay of the land of how the heart looks and how the lung fields look. So you should always take chest x-rays, always take 2 views, and I'll explain why here in a second. So this is chest x-rays on a dog that has a grade 2 murmur that was referred. These are really nice, beautiful technique x-rays, by the way. The arm is pulled out forward out here, out of the way of the chest. The DV is nice and straight. Take it on inspiration when the dog is breathing in, so you get a nice widened chest. So this is a normal heart. So you've got good separation here in between the back of the heart and the spine. The trachea should kind of come down and kind of slope down the back of the heart here. Has nice shape still. And in this view, you've got nice separation here on both sides of the heart, between the heart and the chest walls. It has its nice little heart shape here. This dog kind of has like a mild to moderate bronchial pattern. That's probably why it's coughing. But these are really nice chest x-rays, and I would say that this looks like a normal heart. Versus you have this dog come in as a Pomeranian, and this dog's also coughing. So you take let's say you only took a lateral view. In this view, I think this heart looks big on this lateral view. It's kind of crunched down in there, it's kind of closer to the spine. But remember, Pomeranians are little barrel-chested dogs. Their conformation really matters when you're looking at chest x-rays, so they're wider than they are tall. So if you only took a lateral, this heart would look big to you on an x-ray. So taking that other view is really, really important. So this dog actually has a normal heart, and we echoed it and had normal heart size. Not sure what's going on in this lung over here, but it does have normal heart shape, nice spacing on both sides. So that's why 2 views are so important.
Yes, we have a question from Zoom. Someone had previously heard the BNP in dogs isn't super reliable in comparison to cats. Has this changed?
Do you want me to repeat that question? Okay. So somebody on Zoom asked if BNPs in dogs are less reliable than BNPs in cats. Not really in our experience. We still get BNPs on dogs. Well, people or vets will call and say, well, I wasn't really sure about this dog, and then they check a BNP and it could be high, and that dog could still have significant heart disease. Although I will talk about BNPs a lot more in a little bit, but there are many other reasons why BNPs can be high, so, and that could apply to cats as well. So it's not just like for heart. So there are other factors they have to take in with doing BNPs. Yes?
Two views. How necessary is a third view?
Not really for us. The question we talked about 2 views, how necessary are 3 views? So unless we're looking for metastasis or something like that somewhere, we don't really look for that 3rd view. We just really want to see you in a lateral, and we want to see you in a DV or a VD, because you really, like if we just get, sometimes just a lot of laterals sent, well, you know, you can't see both sides of the chest and the lung field, so we're not really looking necessarily for the 3rd view. 2 views is cool for us. Yeah.
How do you convince your doctor of that?
What's that?
How do you convince your doctor?
Well, and charging the client, right? Because you're charging for 1 view versus 2 views. But if you're going to take 1 view, you really shouldn't take 2. You really can't make a determination on just, 1 view. So you're wasting their money, kind of.
Assuming it's a right lateral, correct?
Right.
Right lateral?
Right lateral, yeah, yeah. So, taking signalment back into account. So this dog was referred to us for an enlarged heart. So this is a greyhound. Did not have a heart murmur. It was coughing, I think, which is why they took the chest x-rays. And it was referred to us because of this chest x-ray here. So when we're looking at this one, this heart does look big in this dog's chest. I mean, there's not much separation here on the side. It just looks big. But then when you take that other view, now this heart looks normal in this dog's chest because this is a greyhound. It's a deep-chested breed, so they're really tall and very narrow. And so again, if we're only taking 1 view, then you're not really getting the full story. So, this dog's trachea kind of comes down right over the back of its heart. There's good separation. So this dog also had a normal echo. So back to our to-do list. We kind of already touched on BNPs. If it were my dog and I was worried about heart disease, I would add on a BNP, and we'll talk about that here in a second, to routine labs, which they should be having anyway. So NT-BNP is a component of a hormone that's released by the myocytes when there's increased stress or stretch on the heart, meaning heart enlargement. Generally, the more dysfunction there is, the more heart enlargement, your BNP goes up, but not always. And keep in mind that this is a hormone. So if you're tracking this over time, so let's say in a dog, you check it and you get 400, and then you check it the next year and it's 800. That's still normal, and a hormone can fluctuate day to day, can fluctuate within the day, or there can be a 20% fluctuation in this over time. So we would still say that that's a normal BNP for that individual. But we do see BNPs go up when you have kidney disease, and it's because that hormone, that's how your body releases that hormone, is through your kidneys, and if you have decreased renal function, then you're going to hold on to more of that hormone, and it's going to come up in higher concentrations on your blood tests. So higher BNPs can be associated with renal disease, if they've got systemic hypertension. Obese animals too will have high BNPs, and not really sure why that is, but we've kind of tracked some overweight cats that we've had work on weight loss over time, and those cats' BNPs came down as they got to be a more normal lean body weight. So if you've got a really fat animal in there and they don't have any other symptoms other than this high BNP, it could be because they're overweight. Other systemic disease, like we had a dog, had a completely normal echo, but he had a brain tumor and his BNP was like 4,000. So there are other reasons. So that's why it's not infallible, and you really have to use it with looking at the signalment, looking at the exam findings and the other diagnostic testing that you're doing. Can't really hang it all on just the BNP, but it is a nice tool. So takeaway from this is do baseline chest x-rays. If you're worried that the heart's enlarged, the BNP is high, and there's other reason for you to believe that this dog might have an issue, start him on some heart medications, we'll talk about in a little bit, while we're waiting on that cardiology referral. We get people all the time that said, well, my vet we're just watching and waiting, and we're just watching this murmur. And then we end up watching it until they go into heart failure. So we don't want to just watch these murmurs if they're willing to go in and get it checked out, because what we want to do is catch it, and so we can put them on medication and manage them and prevent them from ever going into heart failure ever. We're kind of afraid to die from something else other than heart failure. I know it sounds weird to say it that way, but don't want you to die from heart failure. It's not a good way. So advanced valve disease exam findings, these dogs will have a moderate to loud murmur, sometimes a thrill. So if you feel the thrill vibration on them, that's automatically a grade 5 murmur. These dogs will lose their sinus arrhythmias, so their resting heart rates will sometimes be high. And sometimes they'll have premature beats. You can get a little bit of electrical instability when you have a lot of heart enlargement. Really advanced disease, they'll go into AFib, so that's obvious when you listen to them, rapid, irregular heartbeat. Sometimes they'll be coughing, sometimes they're not having any respiratory symptoms, but really try to drill down on owners with the cough. Is it a tracheal cough that they're hearing, or is it like this soft kind of CHF kind of cough? Because you can still get tracheal coughs with heart enlargement, because I'm not going to go back to the x-rays, but heart enlargement, or actually I think I do have an x-ray here, there we go. You can get their trachea pinched up here in between their heart and their vertebrae and compression of some of their main stem bronchi, and that can cause coughing too. And some of these dogs will just cough and cough and cough and cough and then pass out and have cough syncope. So it's important to try to talk to owners and find out what they're hearing at home, so that way if this dog needs cough suppressants on top of its heart medication, you can manage them that way. So obviously this dog has a ginormous heart. It's got loss of its caudal waist back here, kind of squaring off. This dog looks like it has a little bit of perihilar edema, like really big globoid kind of heart in this poor dog. This is severe mitral regurg on an echo. So again, left ventricle, mitral valve, left atrium, right heart is up here. This blue, oops, I don't know how to make that play again. There we go. This blue down here is this giant leak, and it actually, you can kind of see it on color flow, wrap around this entire left atrium. So this is a big valve leak, and so when we talked about toxins kind of rupturing their left atrium, think of it as like erosion. This valve leak is like hitting this wall over and over. It can kind of erode at that wall, and they can actually tear their hearts. So your to-do list for these dogs that are more symptomatic or have loud murmurs, take your 2 Views chest x-rays. We know that dogs with pulmonary edema can also get a secondary pneumonia too, so that can be some of their breathing issues. So that's why, again, chest x-rays are super important. They might need more than just heart medication. And radiographic evidence of CHF can kind of lag a little bit behind clinical signs. So you might have a dog that just started coughing like a day ago, and take x-rays, and you might not see obvious edema, but if you wait like 24 or 48 hours, sometimes it's more obvious. So that can be a little bit tricky, but if you're seeing a big heart, it's got a big murmur, then you're kind of assuming that maybe this patient's at high risk for that. ECGs are important if you're hearing an arrhythmia at all. And then if this patient's in distress, don't be shy, give them some Lasix while they're there. What we don't like to see in referral records is somebody was diagnosed with CHF in the office and then just sent home with nothing. And just sent home with, here's the number to the cardiologist. Well, it's good to go to the cardiologist, but that poor pet was just diagnosed with congestive heart failure and just went home with nothing. And so, is that pet even gonna make it till its referral? So there's a lot that we can do to help support them while they're waiting, and we will never be mad at anybody for starting medication and trying to help somebody while we're trying to get them in to see them. Exercise restriction too. In the meantime, you can tell these people, no letting them run around in the yard, no letting them fly up the stairs. There's that can cause more issues and more episodes of CHF collapse. So our valve disease meds, so you don't have to obviously start them on the gamut of everything, but I'll just kind of go through kind of the typical things that these dogs will end up being on. So vetmedin or promobendin is a positive inotropic drug, so it helps with the pumping power and the contraction of their heart. So it helps to compensate for the fact that they've got this valve leak, and so it helps the pumping power to kind of get better output. Studies show that dogs that are started on vetmedin live longer, and it's safe to use in renal patients. So this is our big heavy lifter drug for valve disease, and then we're going to go at them for the RAS. So we're going to go at them with an ACE inhibitor, sometimes an aldosterone blocker. It is important to know their renal function, which is why it's important to do that lab work ahead of time. Because you should be kind of careful if they do have renal disease, but with an ACE inhibitor, the typical dose is 0.5 mg per kg, and that's at 100, you get 100% of your effect. But at 0.3 mg per kg, you get 80% of your effect, which is fine. So if you're a little bit leery about starting them on it, don't feel like you've got to load them up with medication. There's no benefit to going higher. And so if you're a little bit leery, just dose low, and they're still going to get some effect from that drug. Spironolactone is not a first-line defense for CHF, so if you think somebody's in heart failure, putting them on Spirono is not going to get it done. It's just not, even though it has diuretic properties to it, it's not strong enough to treat CHF. So we use it kind of together with an ACE inhibitor to kind of tie up more of those hormones. But we're not going to use that to treat heart failure. We're going to use Lasix. And so you can always start low. 2 mg per kg is kind of a standard dose. You can always give more, so you don't have to just start them out with a huge dose. You can just always ramp it up. You can always give more. Once you start medications, it's a good idea to have these pets back in a week or two and just check their renal function and electrolytes, make sure they're handling everything okay. So like I mentioned before, part of managing them is medication, but the other part of managing them is all in the owner's hands of managing their lifestyle at home. So they can go for walks and they can do that, but it has to be kind of under control. You don't want these dogs running fences or running upstairs or running around unchecked in the yard, because no amount of medication will keep them out of heart failure if they're allowed to do those things. And as with dogs, as we all know, sometimes they just need some help to be reminded that, you know, shouldn't be doing that. There's no special cardiac diet that we would recommend. A lot of these dogs are older, and so we're not interested in completely trying to revamp their diet and make them eat something they're not used to. We want them to keep eating, we want them to take medications, but we don't want them to take meds in cheese or lunch meat or things that are really high in salt. Like a piece of cheese for us wouldn't be that much sodium, but when you only weigh 10 pounds or 20 pounds or whatever, that's a lot of sodium for them, and we're trying to get away from salt and water retention and not add to it with things that we give them to try to get the meds in. So just try to give them ideas for other ways that they can get the medications into them without doing it in cheese. So moving on, so that was valve disease. So moving on to kind of the next most common thing that we'll see in dogs is DCM. So we're only going to diagnose you with DCM if you have primary myocardial failure. So this means that you don't have myocardial failure because your valve disease just got wildly out of control and now you have myocardial failure. Or the same thing with cats. If you have burnout HCM, they'll have myocardial failure. This is the idiopathic, genetic, or nutritional, which I'll talk about in a second, overall global loss of pumping power of their heart. And so since you have basically, it's a systolic disease, meaning they can't squeeze and contract, it's a forward output failure. And so that'll turn on all those hormones that help to grow them a bigger heart and go into heart failure. So these dogs will have a real big dilated left ventricle, left atrium, sometimes on the right side of their heart too, and it's pretty obvious on chest x-ray. These dogs will just have real big globally large hearts. Typically medium breed and larger breed dogs, we don't usually see this in smaller breed dogs. It's an adult onset thing, a 1 or 2 year progression. Sometimes they'll have arrhythmia, but not always. Like Dobermans can have VPCs as like a precursor to DCM, but that's not true for all breeds. And sometimes they can have APCs or AFib kind of later on in the disease. And obviously there's no surgery to fix your myocytes that aren't working, so we're gonna come at them with medication. So here's our breeds for genetic DCM. I've starred the ones that have genetic testing available through NC State. Dobermans, obviously, giant breed dogs, Great Danes, Boxers can get DCM. Cats, once in a while, will get DCM, so we can't rule them out completely. Cocker Spaniels, too, have some kind of weird predisposition to DCM. So, so the genetic versus nutritional. So when they have the genetic form of the disease, like the Dobermans or Great Danes, those dogs, even if you put them on medication, you can get them to stabilize, but those dogs will always progress. They'll never get better. It's incurable. It's just in their DNA. It's in them genetically. But that's not always the case for nutritional DCM. And so to kind of give you a little background, when this all kind of first started happening years ago, they first thought it might have been a taurine deficiency, and then they figured out, okay, well that's not it. Well, maybe it's grain-free food, meaning like the absence of grains. And then they figured out, well, that's not really true either. What it turns out to be is a lot of the grain-free diets, because they don't have the grains in them, end up adding in other ingredients that tend to be the problem, and those problems are legumes. So peas, pea fibers, chickpeas, lentils, beans, those are the specific ingredients that we think may have a long-term toxicity to your myocytes that actually kill off your myocytes and cause myocardial failure. And so, obviously that doesn't happen for all dogs that eat these diets, because millions of them do, and not millions of them get heart disease, but we do know that some dogs do. And some dogs we can put on medication and change their diet around and get all of their heart function back. We can take them off medications over the course of like 2 or 3 years or so. Some of them make a complete recovery, and some of these dogs don't recover at all. They stay terrible. You can change everything, put them on medication, and they don't do well, and they'll end up succumbing to the disease. So you just don't know who's gonna do what, which is kind of the scary part about it. This is an example of an ingredient list. And the funny thing is, when I was putting this together, I had a friend of mine text me and say, hey, what's a good dog food for my dog? And I was like, well, what are you feeding it now? I mean, maybe what you're feeding it is fine. And so he told me what the diet was, and I went and looked it up. This was the diet that he was feeding his dog. And so we know, obviously, the first ingredient is the most, but then 4 out of the 6 first ingredients in this diet were these, problem ingredients. And then this is all cumulative. When you add these 4 together, now you've just made this the #1 ingredient in this diet. So, I mean, I don't know if his dog would have an issue, but I told him, like, well, if that were my dog, I wouldn't give him that, I would switch his diet. So this was essentially my face when I looked at this. So DCM, Echo, so this dog was also an AFib. So this is, you can see it just not pumping, loss of function here. The rhythm is super rapid and irregular. We have a huge left atrium over here, huge left ventricle. He had right-sided heart enlargement as well. This was a big cane corso that we saw in DCM. So these dogs, usually they won't have issues until they are real close and slipping into heart failure. So the owners might notice that they're kind of lethargic, maybe they're kind of breathing rapid at rest, maybe exercise intolerant, maybe they collapsed while they were trying to run around out in the yard. You won't hear a big loud murmur with this disease, and the reason is that loss of pumping power decreases the velocity of that valve leak, and so it makes it real quiet. And so sometimes they'll just have a grade 2 murmur. You might not hear a murmur at all because that velocity is so low that it's just not loud enough for you to hear. So, so they might have a soft murmur, but these dogs will often just kind of have general exercise intolerance or respiratory symptoms, and increased heart rate on their exam. Weak pulses as well, if you're checking pulses. Oh, the other thing I wanted to mention is I would encourage all nurses to just carry around a stethoscope and listen to pets. That was the only way that I got better at it. They didn't really teach us a lot of that in schools, listening to pets. The only way that you're really going to get better is by listening to what's normal. And so if you listen to, you've got someone really nice and cooperative, just listen to everybody that you can, because sometimes I'll catch things in the exam rooms that maybe the pet won't do in the back when the doctor is listening to them, and that can really help them to try to piece together information. So having 2 sets of eyes is often really nice when they're in the room with the owner versus in the back and the doctor's examining them. So I would encourage everyone to just carry a stethoscope around and listen to as many as you can. So our to-do list for DCM, as always, are chest x-rays if you're worried. These dogs should always have a full set of blood work, because when you have myocardial failure and that forward output failure, you're at high risk for kidney failure too, because your kidneys aren't getting the perfusion that they should. And so when you start putting medications into them, that can really kind of tax their kidneys. So we want kind of to know where they're at baseline, because if they already have some elevated renal values going into it, we have to be really thoughtful about what we're doing with medications. ECG, obviously, if you hear an arrhythmia, medications if they're symptomatic, recommend the exercise restriction to the owners, and if they're feeding something kind of off or weird, have them change the diet too. So the DCM meds are real similar to your valve disease meds. So we're going to put these pets on PIMO to help that squeeze and contraction of their heart. We'll sometimes go up to TID dosing of this. So it's always BID, just baseline, but you can go up to TID, and that's safe to do. But for your ACE inhibitor and your diuretic, we want to go low because, again, these dogs have decreased renal perfusion, so you don't want to pound their kidneys with medication right off the bat. So again, you can always give more. So start low on these doses for them. And antiarrhythmics can be a whole different beast. So I wouldn't typically start antiarrhythmics unless you're sure that that pet's like in AFib or something in the office. Quick about arrhythmogenic cardiomyopathy, because boxers are really popular. So this is the boxer cardiomyopathy, used to be known as arrhythmogenic right ventricular cardiomyopathy, but it's kind of evolved over time and kind of removed the right ventricular because it is a global disease. Average age for these dogs are about 6, so right around kind of mid-adulthood. It's so weird how some of these dogs can be right on the schedule with their age. So again, that's why signalment is so important when you're looking at these dogs. So what arrhythmogenic cardiomyopathy is it's not valve leaks, you're not going to hear a murmur. Their heart muscle gets gradually replaced with fatty or fibrous tissue, which interrupts the normal electrical pathways of your heart, and then you get these arrhythmias. And so those arrhythmias pop up, especially when the dog is active or at high heart rates. And so they'll usually, you'll see them as VPCs on the ECG. And if we can get them through and live through this wicked ventricular arrhythmia, then the long-term complication of this is myocardial failure. Again, this is a genetic disease, so there's no surgery for it. We're just managing them with medication. And boxers can be tested for this. So the breeds at risk here are very short. Boxers, far and wide. English bulldogs, too, will get this. They get like really bad ventricular arrhythmias that are kind of unrewarding to treat, and they don't tend to do well, even on medication. And cats can get arrhythmogenic cardiomyopathy as well. So these dogs will normally present to you because they collapsed at home while they were running around, and they will have no other symptoms. And sometimes you'll get them into the office and you listen to them, and they sound like they have a completely normal rhythm. And so then, okay, we put an ECG on, see if we see any VPCs at all. Some of these dogs just require Holter monitoring for 48 hours to figure out why they collapsed. And again, these episodes happen when the dog is very active. And so when we're treating arrhythmogenic cardiomyopathy with antiarrhythmics, a huge portion of the management for that is lifestyle. So these dogs cannot run around and be crazy, because no amount of antiarrhythmics will save them from having a potentially fatal ventricular arrhythmia when they're really, really active, which is hard because boxers are a really active breed, and so that can sometimes be the hardest part for people. But it really is important for them to know how important exercise restriction is for them. Congenital defects. So when you're listening with your stethoscope, often for the valve disease and stuff, you're kind of listening to them lower on their chest, kind of down at their left apex. When you're listening to puppies and kittens, cram your stethoscope way up into their armpit, because most of the murmurs that you're going to hear for these are going to be at the heart base. So if you're kind of listening further down on their chest, you might miss a soft murmur. So you really kind of have to get way up into their armpits on both sides to listen and see if they have a murmur. The first time you identify a continuous murmur, you'll be really happy. Not for the pet, but it'll be cool for you. Cats, most common congenital defect that we'll see in cats is VSDs. And the only 2 of these that are surgical and that can be surgically repaired or improved are pulmonic stenosis and PDAs. The rest of them are just going to be managed medically. So again, signalment, these are the breeds that we see with aortic stenosis. And I won't go through what these diseases are, but it's important for you in practice to know when these breeds walk in the door, when you're listening to them, what the potential genetic issues that they have. So We're seeing dogs all the time come in from breeders to have us sculpt them prior to breeding and stuff, and these breeds specifically can get subaortic stenosis, and cats too, and cats do terrible with this disease. They don't have a good prognosis at all. Pulmonic stenosis, the brachycephalic breeds, we see tons of it in cats because they just do whatever they want. Cats can get this too. And then on to the cats. So HCM. So HCM, also just like DCM, is a primary myocardial disease. So we're only diagnosing HCM if we've ruled out other reasons for that phenotype. So if you've got thickened left ventricular walls, there's other reasons why that cat might have that, especially if they're over 10. Let's say they have undiagnosed hyperthyroidism, or they have undiagnosed systemic hypertension. Those diseases specifically, thyrotoxic cardiomyopathy and hypertensive cardiomyopathy, can look exactly like HCM, but if it's due to those other issues, treating it for HCM is not really going to help that cat. Maybe it just needs to be treated for its thyroid disease. So we're only going to be diagnosing it with HCM if we ruled out those other things. So HCM is a progressive thickening of its left ventricular walls, and this is a diastolic disease, which I think I'll talk about in the next slide. But instead of having a failure to be able to pump, these cats have a failure of being able to relax and stretch and fill, and part of your cardiac output depends on how well your heart can relax and get enough blood in to then, you know, take out to the next stroke of your heart. And so that's the issue with these ones is, so then we'll give them beta blockers and things like that to help kind of relax their heart and slow their heart rate, because this is that diastolic issue. It's thought that about 15% of cats have this. It's a genetically driven disease. We'll see it in young adults, sometimes kittens, which if they're under a year old and we diagnose them with HCM, it's bad, it's wicked. It will progress. You can put them on tons of medication, and they must have some kind of like really aggressive mutation for it, because those cats don't tend to do very well. So that's not good if you diagnose them when they're young, but typically an adult onset disease. So again, it's immune genetically, so there's no surgery for that. So we're managing you medically with medication. And long-term complications, myocardial failure, congestive heart failure, and arterial thromboembolism, so blood clots. So our breeds for kitties, obviously Maine Coons, we see lots of Sphinxes, we see lots of Bengals. The cats that I've starred have genetic tests available through NC State for some of the mutations, but it's not a fail-safe. So if the cat doesn't have mutations for HCM on this genetic test, it doesn't mean that they can't have it, because we know that not all of the mutations have actually been identified. So the genetic tests that we have are good for the ones that we know about, but we know that there are other mutations out there that cause HCM that there's no test for yet. So if you've got an at-risk breed, then I'd probably, if it were me, be running, you know, BNPs on these breeds every year, just to kind of keep an eye on them. And also anecdotally, orange cats get more heart disease, male cats, but definitely orange cats. We see tons of male and female orange cats with HCM. And then weirdly, Shih Tzus get HCM too. So can't always assume that a Shih Tzu has bowel disease, because they can get HCM, which is a little weirdos. So the progression for HCM, so again, it's the progressive thickening of their left ventricular walls. So these walls get real beefy and thick. Their papillary muscles that anchor their mitral valve are also affected by this. And so you'll just get like a decreased chamber volume here too. So even this blood coming in, there's just not much room for the next stroke of blood to move out, because this chamber is so small now, and these walls get so thickened and non-compliant, which is why they're at risk for heart failure with fluid, like giving them steroids or giving them IV fluids. A lot of intravascular volume changes, like quickly, can put these cats into heart failure, because those thickened left ventricles are really non-compliant and they don't stretch nicely like normal heart tissue does. We'll often see a dynamic obstruction, so they'll get systolic anterior motion of their mitral valve, so their mitral valve here can kind of come up and kiss their septum here and kind of get in the way of the blood flow in this left ventricular outflow tract. And those outflow tract obstructions can really drive that thickening, because it's like if you put your thumb over the hose, all the pressure from behind it kind of has to work harder to get that same amount of water through, and so that's kind of what your heart is sensing. So when you have these obstructions, it does tend to drive the disease, and that's often where the murmurs are coming from too. And also, actually, that's where gallops come from, is when you're hearing a cat and they have a gallop, it's because the blood coming in is kind of hitting these walls, and those walls are real non-compliant and stiff, and you'll get that extra heart sound. So gallops are not a rhythm. You put an ECG on them, they have a normal rhythm. It's an extra heart sound, and it's because of the thickening that they have. So that should always be a red flag if you hear a gallop in a kitty. So their decreased output, just like the other diseases that we talked about, activates RAS, and so then they start increasing their blood volume. It backs up the pressure in their left atrium, and that increases their risk for heart failure, and increases their risk for blood clots. Cats can put CHF anywhere. So dogs will put left-sided heart failure as pulmonary edema in their lungs. Cats put it like wherever they want. They'll put it in their lungs, they'll put it around their lungs in pleural effusion, they'll put it in their pericardial sac, and so any of those things can apply to cats. Blood clots, vulnerable hind legs, and rarely it can happen to a right forelimb as well. And they can also die from sudden acute ventricular arrhythmias, because all this thickened muscle here can disrupt and make your electrical pathways unstable, and then, so that's what some people will say, well, I just kind of, like, my cat just kind of fell over and died, and it's probably because it had a acute ventricular arrhythmia. So this kitty has pericardial effusion. I don't know why it was jumpy like that, but so this dark space around here, this is all fluid around his heart. So this cat's in heart failure. Its walls here are super thick. Its left atrium here is really big and dilated. So this is kind of unfortunately for this cat, a good example of severe HCM with CHF. So HCM is staged as well. We don't really use this a lot in clinical practice, but I thought I would include it since it does actually have some specific staging guidelines through the ACVIM. In cats, like we know, on exam can look like anything. So they can look like a cat that has no murmur, no gallop, and literally have no symptoms on exam, which makes them so tricky, which is why sometimes I think BMPs can be helpful for cats. But sometimes too, if they have an outflow tract obstruction, you'll hear a heart murmur. Usually those murmurs are like grade 2, maybe grade 3. We don't tend to get like grade 4 and up murmurs in cats. Like those are kind of the congenital kind of cat sounding murmurs, but usually these murmurs are like a grade 2, grade 3 murmur. Usually they're breathing fine. Like I've had cats come in with a chest full of pleural effusion, and you would never know it by looking at the cat. So it's just typical cat things. So again, that's why chest x-rays are important. You can get a better idea of what's going on with them by taking those two views. Add on a BNP to their baseline labs. And if that cat's over 10, should automatically have a total T4 added on to that lab work. And if that total T4 is anywhere like near the gray zone, or maybe that cat's been losing weight, or you're concerned that it might be hyperthyroid, just add on a free T4 while you're at it, and just kind of look and just make sure that there's not thyroid disease that's driving these cardiac changes. And again, if it's over 10 years old, renal disease is one of the most common things that we see in cats. In an early renal disease, we know that those cats will be hypertensive because your body's, again, trying to make up for the fact that your kidneys aren't performing, so it bumps up your blood pressure. But those cats with unchecked hypertension can also look like HCM cats, so those cats should always have their blood pressures checked as well. And obviously use the right size cuff for the kitty. usually a size 2 or size 3. If it's too big, you'll get a falsely low reading. If it's too small, you'll get a falsely high reading. So it is important to, make sure you're using the right cuff size for the cat. This kitty had severe HCM, and his x-rays were kind of classic, that like Valentine-shaped heart. So he's got kind of big atria up here and kind of goes down to his apex here, so too wide across the top of the heart here. And this heart just looks too tall for cats. And cat x-rays can be, I think, a little bit harder than dog x-rays. They're not like as obvious. But cat hearts tend to be kind of like longer in their chest, and so I would say this one just kind of looks a little too tall for this cat's chest. So HCM medication, I would never start a beta blocker or a atenolol unless you actually have a diagnosis, because beta blockers decrease your heart rate, and so in relation to that, they decrease your contractility and they decrease your cardiac output. So if you've got a cat that's kind of teetering on the edge of CHF and we start them on a beta blocker, you could actually tip them into heart failure. And so we would always kind of want to know what their cardiac status is before you just put them on a atenolol or something. So that's the only reason I mention that on here, is because people think of that, well, that's the heart drug for cats, and I wouldn't necessarily do that unless you know exactly what you're dealing with that kitty. But it's usually pretty safe to put them on ACE inhibitor and on an aldosterone blocker if they've got good kidney function. That'll help start to tie up some of those hormones that's driving their heart enlargement. And if you're worried about that cat presenting to you in heart failure in the office, then maybe it needs some Lasix, but always dose it on its lean body weight. So if you've got like a 20-pound, fat cat in there, don't base them on that 20 pounds. Like 10 pounds Lasix, or a 10 mg Lasix injection for a kitty is kind of a normal standard dose. So just kind of dose them based on what you think that they should weigh. Plavix can be kind of tricky because it's hard for people to get it into them because it tastes so bad. It's so bitter, and so they try to like mix it in food. Often the cats can smell it. So it's great if they'll take it, but sometimes if we've got a cat on a bunch of medications, including Plavix, and they're just like not taking it in food, sometimes we'll just forget about the Plavix and just say, okay, well, we want you to be on all these other drugs, so we'll just kind of like, we wish you would be on it, but out of all the evils, it's probably, we'd rather get all these other medications. So if it got a big, giant left atrium, it would be nice, but it can be a tricky drug to get into kitties. So do's and don'ts with HCM is, again, rule out those other reasons if it's an older cat that it could look like an HCM cat. So hyperthyroidism and systemic hypertension. Those cats are very sensitive to volume, so you don't want to pound them with IV fluids or even sub-Q fluids. Sometimes you have to be kind of thoughtful for the volume that you're giving and the frequency that you're giving over time. And steroids, especially Depo-Medrol, because it's a long-acting steroid, and once it's in there, you can't take it out. And so steroids, make your body retain water, and so that's not what we would want for a kitty that's kind of on the cusp of trying to go into heart failure. And so, again, if you're hearing a murmur or the cat's showing, giving you other vibes for a heart disease, don't wait. We can, there's lots of things that we can do for them medication-wise, and so we want to prevent those cats from ever going into heart failure, hopefully. And so that's it for the first part. Yeah.
How many blood pressures do you guys take in your office to get a meeting?
We usually, so the question was, how many blood pressures do we usually take in the office in order to average them? So we use a Doppler blood pressure, and so we'll often take 5 measurements. So we'll usually drop the lowest, drop the highest, and then average the other 3. And you kind of want to sometimes if I'm taking it, I'll get 170, and then I get 160, and then I might get 155. I'll usually keep taking it until I can group those numbers. Okay, well now we're around 150, and so so it's a little bit of a judgment call depending on what the readings are. Any other questions? Yes,
As far as the cuff is concerned, we know it's used Velcro.
Yes.
Together. Is it contraindicated to use a small piece of tape to keep that attached to the animal when you blow up the cuff?
so the question was, is the cuffs have Velcro on them, and so is it contraindicated to use a piece of tape to keep the cuff on them? And no, because we do that.
Okay.
I mean, if you're gonna blow up the cuff and it flies off the cat, then that's not really doing you any good, so. I do try to, when, before I even put the cuff on though, I kind of squeeze it in my hand to make sure all the air is out of it before it goes on and make sure it's on there firmly and then keep it.
And then one more question. Obviously, we've all had difficulties taking blood pressures on patients that are moving or uncooperative because they're in the wrong area of the clinic when we're doing so.
Mhm.
Is it contraindicated to slightly blow up the cuff because you can't find the pulse when you're doing that?
So the question was, is it a problem to blow up the cuff slightly to try to find the pulse on like an uncooperative pet? Sometimes what we'll do if we can't, if you're like blowing it up and then it's like you're coming down, it's like, and now you got it, it's 40, okay, well that's not, you know, obviously accurate. Sometimes we'll get it on the upswing. So sometimes we'll blow up the cuff and then kind of listen for when it disappears on the way up. And so sometimes that can be another way that you can try to gauge, like, well, are we wildly high or what are we, and kind of get a better idea. So I don't usually blow it up a little bit ahead of time, I guess, to answer your question, but sometimes we will kind of do it on the upswing too, to get it. Other questions? All right, well, I think that's the end of the first part. So, if everybody, I mean, you want to take like a 10 or 15 minute break or something, and we all want to get started, so y'all can get home? Yes, okay. So, for the second half of the talk, now we get to be electricians. We were plumbers, and now we get to be electricians. Hold on, let me turn on my little laser pointer. So for ECGs, I thought we'd talk about the most common arrhythmias that you'll see in everyday practice. And ECGs can be really intimidating, and I know they really were for me when I was first looking at them, but it actually is a lot easier than you think it is to interpret them. So want everybody to know you don't have to be intimidated. We'll go through it, and there's some really easy steps to interpret ECGs. And then how to take that information and then determine what we can do about it, if anything. So these are the most common arrhythmias that we'll see in everyday practice. So obviously there's more, but these are the ones that we'll just kind of stick to for the purpose of this talk. So some of these arrhythmias some of these rhythms are normal and some are abnormal. And but we'll start out again with kind of a quick review of the anatomy. I know it helps me to kind of figure out like how things should work in order to kind of better understand how things go wrong. So we'll do a quick review of the cardiac conduction system. So we'll start out with the SA node. So this is your heart's natural pacemaker. This is where the impulse should be coming from every time. It's located at the top of the right atrium, and it's controlled by your autonomic nervous system. And so your sympathetic nervous system increases your heart rate, your parasympathetic nervous system decreases it. So it's all regulated without thought. But your SA node sends this signal down, and it rapidly spreads that signal across both of the atria. And that's your atrial contraction or depolarization, which is systole. So your atria contract to then fill up the ventricles. And so that on an ECG, that atrial contraction is your P wave here. And so your AV node is, think of it as like your gatekeeper node. And so the purpose of this is to kind of slow down that impulse that's spread across your atria and give your atria time to fully empty into your ventricles before that impulse is then kind of allowed to spread to your ventricles and create systole and ventricular systole. So it's all like very synchronized, because if that impulse traveled too quickly, it's not synchronized with each other, and the atria don't get a chance to fully empty before the ventricles contract, and then you have decreased output. So that is the PR interval. So between the P wave and the R wave, that's kind of represented by the pause that the AV node gives you on ECG. And then the bundle of His is kind of a bundle of nerve fibers that comes off of your AV node and goes down through the septum and bifurcates into the right and left bundle branch block, or bundle branches, and it spreads through your left ventricles. There we go. And so then your Purkinje fibers are all embedded in the inner layer of your ventricular tissue. And so ventricular depolarization or contraction is represented by the QRS complex here. So that signal then travels down and spreads throughout the ventricles to then create that contraction. And your T wave over here is your ventricles repolarizing or getting ready for the next contraction. And your atria will repolarize too, but you can't see that on an ECG because it's kind of buried in this QRS complex, so you don't actually see the wave associated with atrial repolarization. So this is what I was talking about. It's a lot easier to interpret ECGs than you think, and so I've broken it down with 4 things that you can go through to figure these out. So determine the heart rate. Is the rhythm regular or irregular? Kind of a more complex one that we'll talk about is the relationship between the P wave and the QRS complex. And then the last thing is, does the QRS complex look normal or not? So first thing, so of the rhythms that we'll be talking about for this talk, I've broken them down into heart rates. So our rhythms that have typically normal heart rates, are rhythms that have low heart rates, and then the rhythms that have higher heart rates. So a lot of rhythms you can automatically rule in or out just by knowing the heart rate. So AFib is not going to be super slow, and AV block is not going to be super fast. And so there's some really quick determinations that you can make just based on heart rate alone. And so then the next thing is our rhythm regular or is it irregular? And so of the rhythms that then we'll talk about, now we've broken them down into regular rhythms and irregular rhythms. And so obviously normal sinus rhythm, sinus tachycardia is normal, ventricular tachycardia, scary as that is actually a normal rhythm. And then we've got some irregular rhythms over here. And so how you determine if a rhythm is regular or irregular is looking at your RR interval. So in your QRS complex, you have your QRS. So our R wave here, we're going to look at the interval between that R wave and that R wave and that R wave, and are they happening at a consistent interval? And if they are, then that is a regular rhythm. And if they're not, well then that rhythm is irregular. And so we'll see some examples. So looking at this one, are these RR intervals regular, irregular? I think that looks regular to me. Yeah, it looks like a regular RR interval. And what about this one? So obviously these two are much closer together than this. And this is different than this. And yeah, this is definitely an irregular rhythm. These R waves are not consistent. And so what about this one? We only have a few beats here, but maybe it would have been regular if we didn't completely skip a beat here. So this would be an irregular rhythm because we completely skipped a QRS complex. So looks like some kind of heart block here. Again, VTAC is a regular rhythm, but very, very scary, but yes, it is regular. So then we've determined what the heart rate is, we've determined if the rhythm is regular or irregular. And so now probably the more complex part of it is we're looking at the relationship between our P waves and our QRSs. And so what you wanted, there should be a 1-to-1 ratio for each. So there should be a QRS for every P wave, and there should be a P wave for every QRS. It should be a 1-to-1 ratio. And so P waves can be a little bit hard to see on ECG, especially if you have like a lot of motion artifact. And so kind of how I first started trying to figure out where the P waves are is first find your QRS. That's easy, right? Your QRS complex. Your P wave should be out here in front of it. And if you're kind of looking out in front of all of these are similar amplitude, meaning, you know, the height of the wave. They're out here in front of the QRS complex. And then once we've kind of established where our P waves are, what's the relationship between that and that? So we've got a nice little like space here, which kind of looks like a nice little space over here, which looks like a nice little space over here. So I would say the relationship between these P waves and these QRSs are consistent because it's the same for every single P wave and every single QRS. Versus if you look at this, okay, well, first of all, we skipped a beat over here, but we've got our little P waves over here and our QRSs, but so this little segment here, okay, well, that looks shorter than this segment, which definitely, this one is longer than that one, and then here we skipped a beat completely. So I would say that the relationship between these P waves and the QRS is not consistent. And so this looks like some type of heart block. Same thing with this one here. So this one's a little bit trickier. So we've got our QRSs and trying to identify our P waves here. So this kind of looks like it could be a P wave kind of pretty close to this QRS. I know we've got our T waves back here that look consistent, but then this kind of looks the same amplitude as this and this. So this is probably a P wave, but there's no QRS with it. This QRS doesn't even look like it has a P wave. This one doesn't look like it has any sort of relationship. So this one's kind of buried in it. So this one definitely looks like it's some kind of heart block because those P waves don't have any sort of relationship to those QRSs that follow. And actually, if you look at this one, these P waves are consistent. It's the QRSs that aren't. And so for this rhythm, so this obviously looks like an irregular rhythm because our intervals are irregular. But let's try to figure out where our P waves are. So, okay, so these waves are kind of, looks like they're coming after these QRS complexes. So these look like T waves. And then looking out in front of these QRSs, don't really see like a common amplitude wave that's associated with these at all. And in fact, this baseline kind of looks a little shaky. So I don't think that this rhythm looks like it even has P waves at all. And in fact, it kind of looks like almost the baseline is almost fibrillating, if you get it. So once you've established then the relationship between the P wave and the QRSs, then look at the actual QRSs themselves, and I think this is kind of a pretty easy one for people. A nice normal QRS complex should be normal, like narrow and upright. And so if that electrical impulse follows the correct pathway from the SA node down to AB node and down into the ventricles, and it follows the pathway that it should, your QRS should be upright, it should be narrow, and normal looking. So this tells us that this impulse originated somewhere in the atria above the ventricles, and it followed that normal pathway down into the ventricles to create this QRS complex. A ventricular beat is going to look wider and kind of more bizarre, and it has a lot more negative deflection off of the baseline. than a normal QRS. So this tells us that this beat or this electrical impulse originated somewhere in the ventricles, and so it didn't follow a normal pathway, and so that QRS looks weird and different, and it doesn't look normal. And it's actually a lot more easy to tell when you're kind of putting them next to normal sinus beats. And so we've got sinus beat, and you can see the little P waves off here. And then now we've got a beat that kind of came earlier in time than the next expected beat. We've got a lot of negative deflection here. It's wide, it's bizarre looking. And same with this. This actually looks like more upright, right? But it does look still wide and bizarre, and it's got more negative deflection than our normal sinus beats. So these are both BPCs, but this is multiform, so left bundle branch block and right bundle branch block. But it is easier to kind of pick these out when you've got normal sinus beats to compare them against. And down here, we've got all of our nice little sinus beats. But now we put two of these weird beats together. So now we've got two ventricular origin beats together, so we call these couplets. And so the arrhythmias, again, that we're gonna talk about that you'd see normally in practice. And then when we're talking about the need for intervention, this is what we're talking about. So what is our risk for sudden death? Is this specific rhythm going to cause you to suddenly drop dead? Is this rhythm compromising our cardiac output? So this is important, especially like during anesthesia too. Is it causing low blood pressure, perfusion issues? Do you have to do something about it? Or is there something else going on? So maybe there's not primary conduction issues. Arrhythmias can pop up for lots of different reasons, and so again, there might be other things going on that then you can go and try to look for to try to figure out why this arrhythmia is happening. So sinus arrhythmia, it's a normal rhythm, right, kind of for dogs, not for cats actually. Cats don't have sinus arrhythmias, but dogs do, people do. So it's your heart rate increases on inspiration and decreases on expiration. This is really common in brachycephalic breeds because they have higher vagal tone. So the more vagal tone you have, the lower your heart rate, and the more that you'll see these sinus arrhythmias happen. So you can have a normal to slow heart rate, and when you're looking at these on ECG, the RR interval will be irregular, right? Because it kind of speeds up and then it slows down, and so it is considered an irregular rhythm, but for us it's normal, right? The PR interval is normal, so your P wave and your QRS, those always have normal intervals, normal relationships with each other, and you'll have a normal QRS complex because it followed all the normal pathways and the impulse moved like it should through the heart. So down here, this is a normal sinus arrhythmia. We've got our normal little P waves, but you can tell some of these QRSs are a little bit closer together than other ones. So sinus tachycardia, it's described or defined as sinus rhythm at an excessive rate. So for dogs, we're talking like over 160, cats over 200. The heart rate will look rapid. What happened? I lost my. Maybe my mouse died. So this rhythm will be rapid. The RR interval is regular, so it's a nice regular rhythm. It's just at a faster rate. The PR interval is normal, so the relationship between our P waves and our QRSs are consistent with all of these beats. And we've got a nice, narrow, upright QRS complex because these, again, are following the normal pathways. Sinus tach is always secondary to something else. So never treat the heart rate for sinus tachycardia. There's always a reason why this is happening. And, oops, there can be, oops, let me go back. There we go. And what's the most common thing that we'll see in the office? Well, the pets are stressed out, they're nervous, they're anxious, and so that can drive your heart rate up and they'll be tachycardic, but also as we know, pain can cause that discomfort, fever, infection, systemic disease, underlying heart disease, so like we talked about, and the other one where your heart rate, your sympathetic nervous system kind of drives your heart rate up if your heart is not performing well, so you can be tachycardic from that. Anemia, hypovolemia, some drugs can cause rapid heart rate, so like bronchodilators have effects similar to caffeine, so that can drive your heart rate to be higher. So never go after the heart rate itself. So don't just like, oh, the heart rate's fast and we've got to like slow it down. There's a reason why it's fast, and it's going to be something that you can treat or do something about. I don't know why I keep hitting that button. The problem with sustained sinus tachycardia is if it's sustained for a long period of time, again, with your ventricles not getting enough time in between each beat to relax and stretch and fill, that can compromise your overall cardiac output over time. So as your heart rate increases, like if we graft it and your heart rate goes up, your stroke volume goes down. So the faster your heart rate, the lower your stroke volume. And so if that is sustained over a long period of time, that can really put some stress on the heart, and especially like, again, during anesthesia or something, it can lead to low blood pressure, hypoperfusion. There we go. So determining our risk for intervention for this. So are we at risk for suddenly dying? No, we're not going to suddenly die from sinus tach. Could it compromise our cardiac output? Only if it's sustained for a long period of time, and we're talking like 220, 240. Like it's got to be pretty high and pretty sustained for it to really cause issues for your heart. And is there something else going on? Yes, definitely. Sinus tachycardia, there's definitely some underlying cause. And so that pet doesn't need like an injection of propranolol or anything, just figure out why it has that heart rate and treat that. So on the other end of the spectrum, we've got sinus bradycardia, which is defined as an excessively low, slow heart rate. So for dogs, we're talking like less than 60, cats less than 100. This is common in brachycephalic breeds due to their chronic upper airway obstructions and their high vagal tone. So a lot of these dogs will kind of have slow heart rates. We might not necessarily do anything about them if there's no sign of heart enlargement. So if we echo it, or you do chest x-rays or BNP or something, and it's not having any clinical signs, it doesn't have any heart enlargement, well, and it's a brachycephalic breed, maybe it's just compensated just fine, and we might not have to do anything about that. But if there is evidence of heart enlargement, then often we will kind of go after that with medications to inhibit the RAS and decrease the risk of heart failure. So on ECG, these rhythms will be slower, but usually they're regular. So the RR interval is regular, the PR interval is regular, so this relationship is normal, and then the QRS complex itself is normal. And so reasons why somebody might be bradycardic, and so again, brachycephalic breeds, we'll see this. Primary conduction disease can do it too. Chronic primary respiratory disease is a huge one. So again, they'll have high vagal tone, and so sometimes their heart rates will be real low. But there's some other systemic issues that can cause it. Neurologic disease, ocular issues, GI disease can cause bradycardia. There's some drugs that can cause it, and cardiologists hate dexdomitor. And it's just so cardiodepressive, and they can get really bradycardic. That. There. So, are we at risk for some death for bradycardia? No? Here we go. No. Is it compromising our cardiac output? possibly, if it's slow enough and sustained enough, and so, dogs will typically be like under 50 when, it starts to impact them, and, cats, under 100. And so, there might be something else going on. In that last slide, there's a lot of causes, so, you could, give these pets atropine to see if you could drive up their heart rate. But if it's profoundly slow and it's causing heart enlargement or clinical signs, then that pet actually might need a pacemaker. So APCs, atrial premature contractions. So we can find these with any heart rate. Like I said earlier, it can be normal in Cavaliers. It sounds like a premature beat on exam. So when you're listening to the pet, you'll kind of have their normal rhythm, and then you'll get a beat that's just closer in time than the next expected beat. So on this ECG down here, we've got our like normal QRSs and our little P waves, but this beat kind of looks like it's closer in time than this, and I don't see a P wave down here. They're not associated with P waves because it's not originating from the SA node. It's originating somewhere in the atria, but not from the SA node, so it doesn't have that P wave associated with it. And so it'll show up as a premature beat on an ECG with no P wave. These can be kind of a normal variation, but you can also see this in when you have a lot of atrial enlargement, and it can also happen with some systemic diseases as well. So like I said, it's closer in time than the next expected beat, so it'll sound like, I'm sorry, you have a question?
We have a question from Zoom. Do you think Zen Alpha is better than Dextone?
The question is Zen Alpha better than Dextromethorphan? I can't answer that. I am not sure. I don't have any experience with it, sorry. So APCs, premature beat, it's not associated with sudden death. It doesn't typically compromise cardiac output because they tend to occur in singles, so they're not usually occurring in runs, so it doesn't tend to impact your cardiac output at all. And if you're concerned, if it seems like their rhythm is irregular and you put an ECG on and it looks like they have a lot of APCs and you're concerned about heart disease, then you could do some chest rads on that pad or run a BNP. So AFib, this is going to be pretty obvious when you're listening to this pet. The rhythm is rapid and irregular. They kind of teach it in school, tennis shoes and a dryer kind of rhythm, and it's because there is no normalcy to this rhythm. It's really fast. It sounds really irregular. It's hard sometimes to even get a heart rate because sometimes it's so fast it's kind of hard to count. And so what happens is the atria, the impulses are coming from all over in the atria, so it's not coming from the SA node anymore. And so the atria aren't contracting anymore because it's not following that normal pathway. All these little impulses are coming really rapidly, and so the atria are kind of fibrillating or quivering. And so you're not getting that atrial contraction. And so it kind of desynchronizes everything because, like we talked about, the atria need to empty completely before the ventricles contract. Well, the ventricles are contracting, the atria are quivering, and nothing is in time with anything. And so we've got this irregular rhythm here. There's no P waves associated with it because these impulses are coming from all over in the atria. The QRSs are still our nice normal upright QRSs because it still is supraventricular, meaning it's coming from the atria, so it still follows a normal pathway into the ventricles, so you still get a normal QRS. But remember we kind of talked about that shaky kind of baseline? Sometimes the ECGs can kind of pick up on that quivering that the atria are doing. So if you're kind of concerned ooh, this rhythm looks kind of rapid, it's irregular, not really seeing P waves, this baseline looks kind of shaky, I would be worried about AFib in that one. And AFib is usually always caused by primary heart disease, so a big enlarged heart. So The only exception to that is some giant breed dogs like wolfhounds and stuff like that can get idiopathic, like slow AFib. But they're usually down in like maybe 140-ish heart rate. And those dogs like tend to do fine just staying in AFib, but usually AFib is because you've got some serious underlying heart disease. So the issue again with our quivering atria that aren't contracting, that contraction of your atria provides you 20% of your cardiac output. So that blood that's coming from your atria and emptying into your ventricles and getting ready for that stroke is 20% of your stroke volume. So when you flip into AFib, you lose that 20% just like that. And so as soon as you rhythm convert, 20% of your output is gone. So that's why a lot of these pets will end up decompensating pretty quick. And so maybe they've been kind of riding their heart disease for a while and seeming kind of stable. And then it'll seem like, oh my gosh, they're like crashing and burning over the course of, you know, a few days or maybe weeks, if that. But those dogs will tend to, or cats too, will decompensate pretty quick because now, in addition to their severe heart disease that they probably have, now we've slashed their output by another 20%. And so then they'll end up in heart failure. And unlike people that can rhythm convert, so humans can go from sinus rhythm to AFib and back to sinus rhythm and back into AFib. Dogs don't do that, and cats don't do that either. Once they're in AFib, they're gonna stay there. And so there's no getting them back into sinus rhythm. And so then what you wanna do is try to control their heart rate. And so instead of that like 180, 200, 220 heart rate, because again, if your heart doesn't have time to relax before the next stroke, now your stroke volume is even less. And so we manage their heart rate and slow their heart rate down. Try to get it like 160 or under. And we know that they're gonna stay in AFib, but a slower rhythm is gonna be better for them than staying in that really rapid, crazy rhythm. And so then determining our risk for intervention with AFib, is there a risk for sudden death? Not, oh, yeah, Barb.
Do you have owners monitor heart rate at home for this, since they're usually a little bit more excited when they're in office?
So the question is if we have owners monitor heart rates at home since they're more stressed and excited in office. Usually not, but I feel like a lot of people just kind of notice it on their own, like when their dog is like laying or they're petting their cat or their dog, they put their hand on their chest like, oh my gosh, it feels like really rapid. And a lot of times it's coming along with clinical signs too, because now they're decompensating. And so, so we don't necessarily have them monitor the heart rate, but a lot of times it ends up coming up as just people are kind of watching them and it's like, I feel like my dog's heart is like racing. And so it tends to come up that way. So our risk for sudden death with AFib, not from the rhythm itself, you're not gonna die suddenly from that, but it'll come kind of secondarily, right, in the form of CHF. So does it compromise your cardiac output? Yeah, definitely it does. So like we talked about, 20% of your output is gone. You're in rapid AFib, and so when we treat you, we'll be aiming for a heart rate of 160 or less. And is there something else going on? You have AFib, and say, yeah, usually you're gonna have like some serious structural heart disease and big dilated atria that's causing that rhythm. But we know giant breed dogs can weirdly get slow AFib. And so when we're treating atrial fibrillation, the drug that we'll usually reach for is diltiazem. It's a calcium channel blocker and decreases the ventricular response rate, so we can kind of go after their heart rate that way. And diltiazem is dosed 3 times a day typically, and so it doesn't stay in your system real long, but it can be good at trying to slow their heart rate down. Usually we don't reach for digoxin first. We might layer that on with diltiazem if we're at like a max diltiazem dose and we're not at a heart rate that we like yet. Sometimes we'll layer on some dig, but digoxin has a much more narrow margin of safety and it has a lot more side effects too. So we don't reach for that one right away. We'll try to come at them with diltiazem first. And this is a nice example of atrial fibrillation down here. Not really seeing any P waves. These are our intervals are really irregular, very like shaky baseline down here. So then getting into the heart blocks. So you can have disease of your sinus node too. So sick sinus syndrome. I won't really talk about that because it's not as common as AV block. So AV block is disease of your AV node. And so first degree AV block is kind of not even really worth mentioning. It's kind of on an ECG, you'll see it only and sometimes during anesthesia. But the RR interval is normal, the QRSs are normal. The only thing that you'll see, if you even notice it, is the PR interval is just a little bit longer than it should be. Usually this is just something that you'll see under anesthesia because the impulse is delayed a little bit more through the AV node. So this is like, who cares? Nobody's gonna do anything about this, but since we're doing AV block, I wanted to mention what the first degree one looks like. So second degree AV block, there's different types of it, and you don't really need to get wrapped up in the different types. But basically, now we're looking at irregular like PR intervals, and so the rhythm is going to be irregular because the RR interval is irregular. Like it was regular up here, and we completely skipped a QRS. But when we're looking at the PR interval here, so look at the little spacing here. This spacing is a little further away. This spacing is a little further away still, and then we completely missed a QRS. So this is type 1 AV block, where this will actually kind of like happen in a pattern or a cycle. So the QRS will kind of get progressively further away from the P wave until it gets skipped completely, and then the pattern will repeat after that. And for type 2, is you'll have a regular PR interval. So all of our intervals here between the P wave and the QRS are consistent, but then you'll just get this P wave with no QRS following it at all, and it's because the AV node completely blocked that impulse on that specific beat. And so AV block, we'll see sometimes under anesthesia that can happen. If the heart rate's really slow, you can try atropine or glycopyrrolate to improve conduction through the AV nodes, see if you can drive up their heart rate. If you're seeing it on ECG in the office and the dog is symptomatic, you can do an atropine response test. So hook them up to an ECG, kind of figure out what their heart rate is, give them IV atropine and watch for that response and see if you can drive their heart rate up higher with giving, the anticholinergic. And if you can, and that dog is symptomatic or it has evidence of heart enlargement, then sometimes we can put them on oral medications to help drive up their heart rate at home. So bronchodilators can do that because again, it kind of has an effect similar to caffeine, so that can drive their heart rate up. But if you're doing this atropine response test and you see no improvement in the ventricular response rate or of the heart rate overall, and it's causing that PET issues, or they have an enlarged heart, then we might be sending them off to MSU for a pacemaker. But second degree AV block can be a precursor to third degree because we're talking about disease of the AV nodes. That AV node can become more diseased over time. So you'll still want to kind of keep an eye on them because it can progress and become third degree AV block. So then our risk for determining our risk for intervention. No, we're not going to die suddenly from AV block, second degree AV block. Is it compromising our cardiac output? Not really, unless you have a really high grade second degree AV block. So what these ratios mean is when you have a 3-to-1 ratio, that means that this one had 3 P waves and had 1 QRS. And this one had 4 P waves to 1 QRS. And so the higher grade this is, well then, yeah, we might be getting some cardiac compromise because the heart rate is just driven so low. So some of these heart rates can be, under 50. Something else going on? Yeah, usually it's disease of your conduction system. There's a few breeds that we'll see commonly with this. So again, signalment in cardiology is important, and so we'll see pugs, schnauzers, westies. Yes.
Is this where we would see syncope?
Yes. The question was if we would see syncope with this. And so yes, with a high grade AD block, if you're missing a bunch of QRSs, then yeah, you just don't have the output there to kind of stay on your feet. And so yeah, they can absolutely collapse.
One more question.
Yes.
What would that look like on an EKG? The syncope?
Well, I don't know if I can go back, but that skipping of the QRS, you probably see a really long pause. You might still see P waves in there because your sinus node is still working, but it's just not making it through the AV node. So you're probably just going to see a pause there or just a bunch of skipped QRSs. So third degree AV block, now we've got a super slow heart rate, no relationship between these P waves at all. So these P waves, they're coming at a regular interval, but it looks like they're not, they have no relationship to this QRS. So this one's kind of buried in this QRS, this one's kind of far away. There's a P wave out here by the T wave, this P wave's way out here. And so what this actually means is now we've got some kind of escape rhythm happening. And an escape rhythm is like your body's like emergency backup plan for if none of these impulses are getting through your AV node at all. And so we've got our P waves because our sinus, our SA node is still pumping out those impulses, but they're not making them through. So then, well, how does your heart keep beating then if none of those impulses are getting through? So you go into like your emergency escape rhythm. So the AV node itself actually has some pacemaker cells in it, and so that's next in line. So if your heart is figuring out like, okay, well, these impulses aren't making it through, now I have to dispatch my next emergency, and that is our AV node can generate some impulses to then keep the heart beating. And you'll still see a normal QRS complex. It'll be a nice normal upright QRS because it's generated by the AV node and it's still following the normal pathway through the ventricle. So it'll still look, if I could go back a slide, I'm afraid to mess it up, but if that was an escape rhythm on the last slide, an AV nodal escape rhythm because those QRSs are still normal and upright, versus this rhythm down here, this is a ventricular escape rhythm. And so if your AV node is diseased enough where it's not even pumping out those impulses, now your ventricles as a last ditch effort will take over, and your ventricles will then make these impulses and try to keep your heart beating. And so we know if we see a ventricular escape rhythm, that is more of a medical emergency, because if your ventricles decide that they're kind of done doing that, well, now you're completely done. And so we see our P waves here because our sinus node's still pumping out those P waves, but we've got these wide, bizarre QRSs that look like VPCs that don't have, obviously they're not going to have a relationship to the P wave because they're generated in the ventricular tissue. But it could be easy to look at this rhythm and say, oh, this pet has like VPCs, we need to like suppress this and do something about it. Well, what happens if we just suppress this ventricular rhythm? Yeah. So it's important to know that this, what rhythm you're looking at, and even though it's VPCs and your natural inclination is to do something about it, in this pet, you would never want to do something about that rhythm. That's the only thing keeping that pet alive. But they should definitely be on the fast track to MSU for a pacemaker. And so determining our risk for intervention for third-degree AV block, is there a risk for sudden death? Maybe some of those ventricular escape rhythms, that tells us that that rhythm is unstable. And so you can actually get some more instability in that ventricular rhythm that could potentially cause sudden loss of life. Is it compromising cardiac output? Yeah, absolutely. These rhythms are really slow and inefficient, and so usually these pets are having some kind of clinical signs, so collapse, lethargy, heart enlargement. Is there something else going on? Yeah, we're looking at primary conduction system disease. Sometimes you can get some viral insults, tick-borne diseases, myocarditis can cause these crazy arrhythmias, but in general, we're mostly looking at primary conduction disease. And so then brings us to ventricular arrhythmias. And so again, we've got our wide, bizarre beat down here that occurs closer in time than the next expected beat. It's not associated with a P wave at all. The rhythm is irregular because it's a premature beat, and that's what it'll sound like. So when you're listening to a pet and you hear a premature beat, it could be an APC or it could be a VPC because they sound the same when you listen to them. So you'd actually have to throw an ECG on them to know for sure. But you've got your wide, bizarre, negatively deflected beat down here that's different than our sinus beats. And it's, again, like that because it's originating in the ventricular tissue. So we see a lot of VPCs. So you can see VPCs from primary heart disease, like we talked about. Dobermans can have VPCs as kind of like an early warning for DCM. Obviously, boxers get VPCs with arrhythmogenic cardiomyopathy. But we see VPCs for tons of other reasons. And so you get a 12-year-old golden retriever in, and because the vet heard an irregular rhythm and it's got VPCs, I wouldn't be thinking primary heart disease for that dog. I'd probably be thinking of cancer right away. And so, put an ultrasound probe on them, look at their spleen, take chest x-rays. A lot of systemic disease can cause VPCs, so it's not just a heart issue that can be causing those ventricular beats. There's a lot of systemic badness that can be causing that. And under anesthesia, this is common to see with splenectomies, GVDs, or GDDs can cause ventricular arrhythmias, so that's common like intraoperatively and also postoperatively. So with ventricular arrhythmias, they're not necessarily dangerous if you're just kind of having some intermittent single beats. It's not really compromising your cardiac output, but the more complex the arrhythmia, the more dangerous it is. And so when we're talking about complexity, we're talking about putting those abnormal beats together in combinations, or those beats are originating from different spots inside the ventricular tissue. So again, we've got like this kind of not normal, but upright kind of looking VPC here. But then this one kind of looks different than this one. And so this is left bundle branch block, right bundle branch block. This tells us that there's more instability because those impulses are coming from different points in the ventricles. So the more you put them together in combination, so like here's a couplet down here, they can be in couplets, they can be in triplets, so 3 beats together. 4 beats or more is considered a run. Obviously, sustained tachycardia is a problem. But yeah, we worry more when you're putting these together in combinations, or it's looking more multiform or multifocal. And or if it's driving your heart rate, like if you're having a bunch of these beats together and your overall heart rate is higher, then we know, okay, well, we probably have decreased cardiac output because now we have this like fast, like inefficient rhythm, and so that probably will compromise our output. Grading arrhythmias, I won't be testing anybody on this, but grade 1 and 2 typically not really gonna, like if this is under anesthesia or something, we're really probably not gonna do anything about this. We're gonna be watching that pet's blood pressure, watching its perfusion. If it has some VPCs, we'll probably recover that pet afterwards and kind of seeing if we're still having an issue. Obviously, if we're getting into more complexity with our ventricular rhythm, that's gonna make us worry more that there's like something else going on. And obviously, if you've got like runs and VTAC, then that's more of a medical emergency. Did you have a question?
Yes. From Zoom, if I run genetic testing in a 3-year-old asymptomatic dog for DCM, it comes back positive or effective, what are the next steps? Yearly echo, more frequent monitoring?
So that's a great question. So Dobermans, we know that they can still genetically test, but again, I think they have identified some of those mutations and maybe not all of them. But really for Dobermans, the gold standard is annual echoes, and Holters, honestly, like, it's kind of a pain, but just because we're echoing them once and getting one Holter doesn't mean that that dog can't develop DCM, you know, a year or 2 or 3 later. So really for Dobermans, the recommendation from cardiologists is going to be to echo and Holter that dog every year. Yeah, thanks. So our risk for sudden death for ventricular arrhythmias, maybe if the arrhythmia is complex enough, and again, looking at the signalment, if this is a boxer and it's running around and collapsing and having a lot of this complexity, then yeah, I would worry that that pet could die running around in the yard. Versus if we just kind of have this intermittent arrhythmia, there's no other underlying heart disease, we might go looking for cancer somewhere, but it does, a lot of it can depend on the complexity of the arrhythmia. Does it compromise cardiac output? Again, maybe if it's complex enough and the heart rate is high enough, then you can get cardiac output compromised. And is there something else going on? Yeah, usually it's caused by something else. So whether it's primary heart disease like DCM or arrhythmogenic cardiomyopathy or neoplasia or some kind of systemic disease, usually there is some kind of reason for that. And that's it. Alright, so we've got, yeah, I'm glad that didn't go as long as the last one. Does anybody else have any